A very good evening to everybody. Welcome to another episode of The Different News. Today, we are here with our very interesting and renowned guest, Dr. Kausik Chatterjee. Welcome, Dr. Chatterjee, and thank you for accepting my invite on the Different News podcast.
Thank you.
So, today we are going to talk about a very interesting and advanced field in terms of cancer diagnosis, that is nuclear medicine and PET scan. So, before I go into my questions, I would definitely love to introduce our guest to all of you. So, Dr. Kaushik is an alumni of North Bengal Medical College, West Bengal, India. He has done his post graduation from Radiation Medicine Center, Tata Memorial Hospital, Mumbai. Have also done a fellowship in oncology imaging from Ville Cancer Institute, McGill University, Montreal, Canada. He has more than 30 years of experience in nuclear medicine. He has served as senior consultant and head of nuclear medicine department at National Cancer Institute, Nagpur, and currently he is working at Anandaloke PET CT Scan Center, Siliguri. He has presented several research papers at national and international conferences, and to noteworthy is that he has Best Paper Awards at Asia Oceania Nuclear Medicine Conference and ANMPI Conference and National Consortium of Breast Cancer of North American Conference. He has also published many papers in reputed national and international journals. He is an accredited teacher at Andhra University and Nagpur University and faculty member of master classes for DNB Medical Oncology and panel teacher for Radiation Safety Department BARC and AERB. And he is also the former member of International Advisory Committee of North American Consortium of Breast Cancer. We are very pleased to have you today here, Dr. Chatterjee, and I think I have a lot of questions and doubts to clear from you regarding this fantastic field of cancer diagnosis. Um, so, can you brief us your journey a bit before we go into asking questions? Actually, how
Well,
you got interested in specifically nuclear medicine? Yeah.
so it was a chance, joining this field. Like after completion of my MBBS, I came to know about this discipline. Nuclear medicine was never a part of the MBBS curriculum, so my knowledge was limited. I visited BRC RMC Radiation Medicine Center, Mumbai, which is run by BRC, Bhabha Atomic Research Center, and it is housed in Tata Memorial Cancer Institute. Uh, After seeing the department, after seeing a different approach of diagnosis, it really attracted me. One of the major reasons is that whatever we learned during our MBBS days, imaging means a structural imaging. So we see the things. The first time I come across the idea of functional imaging, which looking at the function of different organ system or rather deviation from the normal functioning of different organs and tissues. As we know that when we call a disease, it is the pathology, that is the deviation from the normal function or normal physiology. So that really appealed to me. Like instead of looking at the structure, we should be able to somewhere capture the abnormality in the function. And if it can be done pictorially, then it is definitely more appealing and more easy to relate. So that way, nuclear medicine offers a very unique option of looking into the disease instead of looking at the structured abnormalities, which usually take place a little later part of the disease. The functional abnormalities usually precede, so that when nuclear medicine can pick up a disease at an earlier stage. To start with, PET CT scan was not in the picture when I did it in 1993-4. PET CT scan was yet to come. There was PET scan, positron emission tomography, but CT was still not fused. So we had some exposure to PET scan, but the PET scan was not available in India at that point of time. And our majority of the imaging was done by gamma camera. So gamma camera uses radioisotopes, which is administered to the patient's body, and then we do the imaging. And when I went through the different procedures, it really appealed to me for two reasons. One is what I already told, that is the functional imaging, which is a different way or different perspective of looking into the disease. And second thing was a treatment option. Like in nuclear medicine, the radioisotopes are used as tracers for diagnosis, and it is used as a magic bullet for the therapy. So the limitation of cancer therapy is the dosage or the total whether it is chemotherapeutic agent or it is a radiation, how much radiation or chemotherapy can be given to the cancer cells. And the chemotherapeutic agent which is used in cancer, they are essentially they are cytotoxic, which is toxic to the cells. So obviously, whenever we treat a cancer cells, the cancer cells being a part of our body, the same, same medicine which we are using as a, for treatment, it is also acting as a poison to the body, normal body cells. So to get the optimum response, we have to deliver it only to the cancer cells, sparing as much as possible the normal cells. So nuclear medicine also gives you that direction, and I felt that this is a very good opportunity, and this has a lot of potential to develop kind of targeted therapy. So these are the things which initially attracted me. Of course, so many things happened down the line, and nuclear medicine, when I passed out, the openings were very limited. But then, well, I carried on with the journey, and one of my major targets was to go to a place where there is no nuclear medicine and start the department instead of gathering. My mentor, Dr. R.D. Lele, was my mentor, as well as he's considered to be the father of nuclear medicine in India by many. He told me that don't join a hospital in Mumbai or Delhi where already there are a lot of nuclear medicine people. Nuclear medicine is not going to spread unless you go to the relatively less known or the farther away from the metro cities and address the hinterland of India. So that's how I kept on moving. I went to places where there was no nuclear medicine, tried to develop the discipline, tried to set up a hospital. So this happened this time also. So I was working in Nagpur. When I initially joined Nagpur, that was the only center in central India. When I first joined in Gujarat, in the Surat Government Medical College, that was the first department, government department in entire Gujarat. And in North Bengal, there was no setup. So that is also one of the reasons I wanted to come and try my hand here.
I think it's an amazing journey, and it's like you have been a pioneer in this field. I must say that.
At least at places.
Yeah. So, if I may ask you, like you have already explained what we gotten some idea about nuclear medicine and PET scan. So, a very simple question to understand that what is the basic difference between the traditional scans like MRI or the CT
Conventional
scan?
imaging, what we call, yes.
Yes, exactly. So, what is
Say,
the basic difference?
yes, tell me. Sorry for interrupting.
Yeah, I was asking what is the basic difference between the conventional imaging and particularly when we talk about PET scan or nuclear medicine per se. Yeah.
To start with, the conventional imaging was restricted to image the structural abnormalities. Like when you take an X-ray, you see the structural abnormality. Next step was CT scan. Again, you were taking the different slices, but again the structural abnormality. In course of time, magnetic resonance imaging or MRI that started giving you a certain perspective or a certain it started revealing the functional abnormalities also. So that way, MRI is also a kind of functional imaging. There is something called functional MRI, and quite interestingly, MRI initially was a part of nuclear medicine because it was at that point of time it was called the nuclear magnetic resonance or NMR. But down the line, that nuclear word has been taken away, and later on, it became a kind of more of a. Initially, MRI was more of a kind of structural imaging, but there are a lot of functional imaging possible with nuclear medicine. Sorry, with MRI. And in nuclear medicine, the objective or the target was from the beginning was to see the function. As I told that in a disease, when there is an abnormality in the function or there is a deviation, departure from the normal function or normal physiology, then that can be picked up at an early stage if you are looking at it from the functional point of view. So this perspective helps you in diagnosing a disease differently and also tells you about the functional abnormalities or the degree of functional abnormalities. Another advantage of nuclear medicine is the quantification. So you can quantify different body functions. Like in case of kidney function, we can calculate glomerular filtration rate, which is the unit. We can also calculate the tubular function. So that way we can, segregate the different functional component, and accordingly we can diagnose the certain conditions and also plan the management. Down the line, there was positron emission tomography. Positron emission tomography initially was completely only a functional imaging, but then in 1999 there was this positron emission tomograph was fused with computerized tomography. So CT, what we now see is a PET CT, where you get a hybrid image. So you see the functional image of positron emission tomography, which tells us about various things. Like in case of FDG PET, we see the metabolic status of different cells or the utilization of glucose by different cells. In case of PSMA scan, PSMA PET CT, we see the expression of certain receptors. So that those informations are now fused with the conventional images of CT. So we get both structural images as well as the functional images fused together, and based on that we make the diagnosis.
Thank you for that answer. Well, while you speak, I was just thinking, you told about functional MRI. That is, as far as I understand or know, I don't have a vast knowledge in the field. Is it fMRI that like where we put some
Yes.
dyes and we see the
Dyes, contrasts are used, but not
contrast?
necessarily. But contrasts, the dyes or contrasts are used in MRI, mainly
Hmm.
gadolinium, which is a kind of magnetic substance. And in case of nuclear medicine, we use radioisotopes, radio tracers. For the purpose of the CT scan, we can either use a contrast to do
Okay.
a contrast enhanced CT scan, or we
Mhm.
can do a non-contrast enhanced CT scan, non-contrast CT scan or NCCT. So depending on the conditions, we plan whether we want an NCCT or we want a contrast enhanced CT scan, which is fused with the nuclear medicine images. Nuclear medicine images were acquired after giving certain radioisotopes, which are essentially the metabolites, or they
Okay.
bind with receptors.
Hmm.
So it's a bread and butter, or the workhorse of nuclear medicine imaging or PET CT imaging is the FDG, fluorodeoxyglucose PET CT scan, where a glucose analog is used, which is
Hmm.
taken up by different cells, as glucose is the ubiquitous metabolite for all the cells, as well as it is also concentrated predominantly by the cancer cells, because cancer cells, because of its glycolytic pathway, because it deviates from the normal, respiratory mechanism, and they use glucose more for both reasons. One is there are so many theories about it, but whatever. I mean, cancer cells use more glucose. So if we use an glucose which is tagged with an isotope, the cancer cells concentrate glucose more than the normal cells. And we can find out these are the areas where the cancer cells are there. Besides also receptor imaging, we use PSMA, we use FES, that is we can image the expression of certain hormone receptors like estrogen receptors in breast cancer. The same way we can also image the somatostatin receptor expression. Then there is FAPI, so different plasminogen expression. So all these things are taken into consideration for finding a disease, as well as to understand both the spread as well as the extent, which we call spread, as well as the gravity of the disease, or the how serious the disease is. So how aggressive the disease is. So both purposes are served by doing this kind of metabolic imaging.
So, when it comes to cancer, the first thing that comes in a clinician's mind is more about, like any kind of cancer of the body, is about early diagnosis. So, like you said, I mean, it's a very fantastic advanced technology that we are having at hand today with nuclear medicine. So, does it really help in early diagnosis, in a sense, like when we sometimes don't have clinical symptoms as such, or is it more like we can understand the transformation or transition from a benign to metastatic, that transition? So where do you think nuclear medicine has more effectivity in that way?
As it on today, first baseline diagnosis is rarely done by PET CT scan. We do it for several reasons, but one of the reasons is that when there is a suspicion, either because of certain tumor markers have changed, or there are some on a CT scan or an MRI, you find certain lesions somewhere, some kind of abnormality, and the overall clinical picture is suggesting there is a possibility of cancer. So there we do the scan to confirm whether this is most likely a cancer. We cannot confirm it beyond a certain doubt, because ultimately it has to be proven by histopathology. But at least we can give you a strong clue that it is more likely to be cancer. So differentiating between a benign condition and a malignant condition, there is one. But more commonly, it is used to understand how much the cancer has spread and whether it is responding to the treatment. So we call it staging, to find out what is the present status of the cancer, to what extent the cancer has invaded the body, human body, and secondly, when you are treating the patient, whether the patient is responding. So this response evaluation is very, very important, because nowadays in case of cancer therapy, there is something called tailor-made therapy. So it is not previously like there was a set of drugs has to be given in certain kind of cancers. Nowadays you keep on manipulating the combination of
Right.
medicines, and now you have immunotherapy options also. So sometimes there are a combination of radiation, immunotherapy, chemotherapy agents, and once you try one regime of drug, and then if you see that it is responding, then you stick to that medicine or that regime. On the other hand, if it is not responding or it is not giving you the desired result, then you might shift, or you might either escalate or switch over to different group of medicines. So that is very important in cancer therapy, because all the medicines, as I told, majority of the cancer medicines are quite toxic. So giving medicine unnecessarily will really lead to detrimental effects on health. And of course, diagnosis also, early diagnosis. Mostly the staging part is important. There is a cancer somewhere, because the tumor markers are suggesting, or clinic symptomatically the patient is presenting with certain symptoms which are closely relating it to a cancer diagnosis. But then finally, to know whether the cancer is limited to only one part or it has spread to any other part. If it is limited to one part, how minimal it is invasive. So these informations actually are key points for planning the management. So this is major role of one is the treatment response evaluation, another is the staging. And initial diagnosis, yes, but not necessarily it is a baseline diagnostic tool. Like someone has come, just I want to rule out cancer. No, PET CT does not really is recommended for that kind of setting. Though I come across many people who come and wanted a PET CT to be done to rule out any cancer in the body. PET CT, because glucose is an ubiquitous agent, it concentrates not only in cancer cells but many other conditions. So unless you have
Right.
a overall clinical workup and
Mm,
strong suspicion, PET CT is
mm.
an over. Many times it is misleading. So you have to know where you have to use a particular modality.
I think it's a very interesting conversation that we are doing today. So when it comes to PET scans, like uh, does it help in actually guiding treatment decisions in terms of like when we are seeing the effectiveness of any particular treatment modality that you were mentioning? So, for example, it can be radiation therapy or chemotherapy. So, can you tell us something about that? Like how exactly PET scan guides the treatment planning?
See, one thumb rule of cancer treatment, that if the cancer is localized and it is smaller in size, then resect it, remove it, and then tackle the rest of the things with other agents. If it has gone to a point when maybe the surgery is not possible, you treat it with chemotherapy, immunotherapy, radiation therapy. Though it is not always applicable in all conditions, because nowadays there are chemoradiation therapy. Even if there is an option of surgery, you may not go for surgery and can still opt for other modalities. Immunotherapy is one. Immunotherapy usually is used as a supportive one, but many times in particular type of cancers, you straight away you might opt for immunotherapy. So there are a lot of options. But yes, nuclear medicine or rather PET CT scan definitely gives you a good clue about the invasiveness of the disease and the spread of the disease, and based on that, the management strategy is made. So that gives you not only a clue, a direction, also helps you in at least making the options clear. Like you have this is option for particular kind of cancer, whether you want to go for a surgery or a stereotactic radiation or a very localized radiation or a chemotherapy. All these options a doctor take into account, and looking at the patient's overall profile, the tolerance of the patient to certain kind of therapy, the decision is taken. And usually you have that luxury of choosing the best one of the lot.
Okay, so I have an interesting question which was running in my mind. In terms of like I would go to the on the shoes of patients. So as we know, like as clinicians, of course, you also have a vast experience. Sometimes, particularly when dealing with this kind of dreadful medical conditions like cancer, sometimes patients get a perception that they are burdened, and they're already burdened, and they're being burdened with more kind of diagnostic modalities. So, can you simplify and tell for the public that exactly where the clinician is actually, why the clinician is suggesting a PET scan or advanced scan like this or treatment like this? And uh, what would be your answer if somebody asks you this, like, why are you giving me another scan? So yeah, I think that way I
Right.
will put it.
Quite natural that it will occur to someone's mind, and people say that you keep on doing so many tests one after the other. But there is a pyramid of tests. Like initially, you do the baseline tests, and above everything, I believe that the clinical evaluation is the most important component of a diagnosis. Despite of the fact that you have so many, entire gamut of imaging, blood tests, this, that. Ultimately, the initial diagnosis should start at the point of clinical diagnosis, taking a good history, looking at the patient's family history, patient's demography, where the patient has come from, what is the age of the patient. So all these things are the first line of investigation. It is not investigation; it is the diagnostic approach. So once you go through that, and then you kind of shortlisting it. So at every point, you are supposed to rule out the certain options. Like if you know that this is a tuberculosis, say clinically, then instead of trying to rule out some disease which is less likely, you first try to establish whether it is tuberculosis or not. So there comes the first set of tests. So that test, if it fails to establish the diagnosis, or you find these are coming negative, then you go to the another set of tests. That's how usually everyone. I mean, it is the natural approach of life. Like you try one set of options, which it's not working, then you go to another set. So in case of diagnostic modality, I feel that you have to go by that particular design. So you first use cheaper and best level investigations, and then once those are not being able to establish a disease, you go to second set of investigation. So many a times when you have that luxury of doing so many tests, sometimes people overdo, because they don't want to take any risk. They want to do all the tests so that nothing is missed. But I think a good clinician or a good doctor usually go by two things: one, the clinical diagnosis, and definitely the doctor's own other beyond that clinical diagnosis. There is something called a hunch. Especially an experienced doctor, they know that these are the possibilities which might be missing. My the tests are not being able to establish, but something I'm missing, and they think and try to find out. It is like in a detective story. The detective is searching for the clues, and from the clue they try to come to a conclusion, and sometimes you fail to reach a conclusion, then you again search for further new clues. So that's how a patient is approached to diagnose the disease. Or rather, I will say the disease is approached to find it out, what kind of disease the patient is suffering. So I'm definitely against using different imaging modality or different test modalities indiscriminately. I think that is one major teaching, or that is one of the major characteristic of a good doctor. They don't use too many tests. They use only a particular set of tests to come to a conclusion, and when that test fails to establish it, then only they go to a higher modality. But at the same time, when you have options, you definitely are not going to leave any stone unturned. So what many patients, many of my, even my uh, father used to say that previously we used to go to a doctor, they used to put a stethoscope and they find out. Nowadays, why you need that? So I said that when you have the technology, previously you used to do in a different way. Nowadays, when you have advanced technology, you want to do it better. So if you look at the previous records, like older in the history book, if you go back, you'll find so many things were missed. People used to accept it because that is a limitation. Even today, so many things are missed because today also we have limitations. Down the line, if you have another set of investigation which might be more sensitive, why should you not use it? I mean, just for sake that people are thinking that you are overdoing it. But yes, you should not overdo. You should be careful. You should be able to justify every investigation you are doing, every scan you are doing. Sometimes there could be another scan just because you are not being able to come to a conclusive point. Then you may need to go for the next set of investigations. And of course, the cost effectivity in a setup like India, or for that matter anywhere, you have to take into account unnecessary expenditure, whether it's a burden on the state or whether it is a burden on the patient. So you should be careful about choosing the investigation. That's why I personally always discourage, don't do PET scan as the initial first line of investigation. It should come much later in the ladder. So you first do a set of other tests, then you go to the PET scan down the line.
Thank you for that wonderful answer. So, so we have talked much. We have understood this area. We got a kind of comprehensive idea from you. But like with every technology, we have some pros and cons. So, is there any limitations with the PET scan? Would you like to talk about if there is something like that?
There are always limitations. With every investigation, there is always some limitation. And in PET scan also, you should know where the limitation is. That is very important. Many a times I find the referring doctors either have an over expectation by doing a PET scan, they want all the answers. I am very, very skeptical. I always say when I'm not sure, I always put it on paper, like on writing, and I'm not very sure about it. And many times there is a kind of different schools. Some doctors they say that if there is a 70% chance, I'll say this is the diagnosis, because anyway, if it is getting ruled out also, you cannot keep the physician, or you cannot put all the doubts in the mind of the clinician. I look at it differently. I think that I'll put it on writing clearly that I am most likely this is particular disease, but there are possibility of the other conditions. If I know about the conditions, I'll put it in on writing, and perhaps I'll suggest you can rule that out by doing a certain scan. So this kind that is there are two schools of reporting. I belong to the second school when I put it down on paper that if I am doubtful about the diagnosis, I write it down that there I am not very sure that there is a differential diagnosis or there are two or three differential diagnoses. So that should be ruled out step by step. Many times the clinician knows that these are the certain things which does not happen, is not possible because of the overall background of the patient. And sometimes even may not be knowing it because the clinician is seeing the patient for a long time. I am seeing the patient only once, and many times I am not examining the patient fully, or I am not privy to all the investigations done to the patient. In India, especially, people don't want to show you the previous reports even, and they feel that if they show me a previous scan report or a previous blood test report, that is going to bias me. So they just hide it. So in those cases, it is better to mention it clearly that there are the areas, these are the possibilities, and these are the things which has to be ruled out. And in my experience, long experience, I have come across cases when I have actually missed the main diagnosis and got misdirected because of certain things, and that also taught me. I think everyone learns through their mistakes. So I have also learned, especially differentiating between tuberculosis and cancer, maybe sometimes quite tricky, because tuberculosis many times presents with a picture where you start believing it is cancer because the doctor has sent to you to rule out certain cancer. So you're already a kind of biased mind. You are approaching the patient with a
Okay.
biased mind. So when
Hmm.
you look at it, like if you have the ability to go through all the details of the records, talking to the referring physician, then slowly your diagnosis becomes more accurate, or about your limitation. And I believe one of the major goal of a doctor, good doctor, is to know one's own limitation, or the knowing one's modalities limitation. Otherwise, you are going to miss the bullseye.
Absolutely, absolutely. Dr. Chatterjee, one thing, like, because this field is ever emerging, the advanced diagnostics part, particularly this area. So, uh, what emerging trends or innovations do you foresee in the area of PET scan or nuclear medicine? If I put that way, I mean, what excites you most when it comes to advancements of this field?
See, one major issue in India is that price of any test. So what I first foresee is that dropping in the price, because as the technology is getting advanced, as there are more and more number of centers are opening up. So
Right.
previously, a PET CT scan was quite out of the reach of common people when it first started. Even in US and Europe, it is still quite expensive. In India, because of the larger population or the bigger uh, number of patients, things are becoming a little less expensive. And many things are coming up. They are coming up with cheaper technology, easy availability of the medicine, even the good air connectivity between different these B cities or smaller cities with the major cities. So I first of all I believe that down the line, PET CT scan is going to be more affordable, easily available. Everyone can go for it. Previously, for doing a PET CT scan, people has to go to a major city, just traveling, staying there, made many people refraining, staying different from doing that scan, or they could not afford to go for the scan. So technology has made it easier, and of course, with the development of the cameras, better, electronic, supporting system, more number of people are going to get access. In fact, that excites me more than a new technology coming and taking over. Perhaps new isotopes are going to come, new radiopharmaceuticals are going to come, better cameras are going to come. But for me, that is just going to be like adding little bit of advantage over the present advantage. But most important thing is that making it available, making it price friendly, making it people should get the access. The doctors should use that technology more and more, and which is happening. In just 10 years back, I remember in 2000 in Nagpur, one of our 2002 or 2003, uh, one of our very good friends and an oncologist, he asked me then, when you foresee, Kausik, when you foresee a nuclear medicine, I mean a PET CT scan in Nagpur. I said not in near future, because PET CT scan, in order to support that, you need a really well trained team, which is not very easily available in a smaller place like Nagpur. Maybe Delhi can afford, Bombay can afford, Nagpur cannot afford. I said this sometime in 2003, 2004, and by 2010 we had a PET CT scan, and by 2013 there are 3, 4 PET CT scan, I mean centers, and today Nagpur has 13. So that excites me more rather than the advancement in number of type
Right.
of scans we're doing. We're still doing FDG PET scan mostly, and we
Right.
also have other pharmaceutical agents for doing more specific, more focused scan, like I told before, somatostatin
Yeah.
receptor imaging, dopa receptor imaging, PSMA, prostate
Hmm.
specific membrane antigen imaging. So these are the things which are coming in the way. But and if you really ask me what is the field which appeals most to me, or I find is
Hmm.
most exciting, is the treatment options. New
Hmm.
treatments are coming, and it is going to have a major say in the cancer treatment, because of, as I told you, it's a targeted therapy. The collateral damage to the normal cells are less. We
Right.
can hit the cancer cells by and spare the normal cells more with this particular line of therapy, and that is going to make a sea change. In fact, that is what excites me more than diagnostic aspect.
Um, I think we are almost at the concluding part of our conversation. But before you go, I would really like to know that it's an interesting area which I actually delve in, and I study a lot in terms of molecular diagnostics. It might not be exactly what we are talking about, but when you say that this excites you when new technologies are coming and basically understanding cancer faster, so uh, do you think that the awareness about this kind of fields, whether it is molecular diagnostics or nuclear medicine, among our medical fraternity as well as among common public, do you think that awareness has to grow more, or it is like it's already there? Because I think both way, it's a both way communication when it comes to doctor and patient. So how what would be your opinion or take on this?
It's a very, very interesting question. I think this is one area which we missed during our discussion.
Right.
Incidentally, FDG PET CT scan, when it was first introduced, or rather, when we came to know about it, we knew it by the term that molecular imaging. In fact, today also, PET CT scan, or especially the different, not only glucose scan, but other scans also, we call it molecular imaging. Because ultimately, our target is the molecule. And we want to characterize the even tumor biology by doing the scan. It is not just seeing the size of the tumor or how much it has invaded, but rather more what is the biology, like which part of the cells, which part of the cancers is most active, which part is having more necrotic tissue, what is the proportion between the two, what kind of receptors are being expressed. Because as it happens, like in breast cancer, the breast cancer, there are different type of breast cancer. Some
Yeah.
are hormone sensitive, and some are not hormone
Huh.
sensitive. There are also different type of receptor expression by the cancer cells, and depending on that, your not only your treatment protocol changes, but also your approach changes. Because when the first breast cancer was targeted, I mean, diagnosis, the only therapy available for breast cancer to start with was surgery. And there was one famous surgeon, Dr. Halstead, who believed in cutting it off, cut off as much as possible. And sometimes his operation not only included the breast, but even the muscles, the collarbone, even the chest muscles, ribs, everything is to chop it off. With the idea that if you take away much and much of the the cancer tissues, assuming that the cancer has micro spread to the different parts which we cannot see, so take away as much as possible. But down the line, it was proved that cancer is not like that it is a systemic disease, and it is not that localized disease. So you have to approach it completely differently. And again, I mean, you understood that there is some hormone receptors expression, and some can be targeted by using certain anti-hormone therapies.
Yes.
So if you can block those receptors, the cancer cells do not grow because they are not getting their stimulus. And
Right.
those are the different understanding. I mean, those are the different approaches which change the understanding of cancer. So these are all cellular and molecular understanding. And PET CT scan and especially nuclear medicine, all sorts of nuclear medicine scan, they look to that. Like essentially, you want to characterize the tumor biology, not the
Hmm.
tumor spread, but the tumor biology. So that's what I said, that in case of a particular receptor imaging, you see what kind of receptors being expressed by the cancer cells. Or
Correct.
nowadays, even there are certain mutations which can be picked up by imaging. So
Exactly.
that is going to make a huge difference in understanding the disease, and the doctors have started, appreciating it. As it happens, it takes time to percolate down. Initially, everyone wanted to, operate it, remove it, but then in the 50s, the people started understanding it's a systemic disease, and you should approach, instead of cutting it off, you approach it from the systemic perspective. Then the people understood it is also based on your immunological status, and that is again, it can be imaged also. You can find out where there is a PDL expression, PDL1 expression or not. So those are the things which you can even image. And if you can image, then you can take action accordingly. So, well, the entire approach to the cancer therapy, especially in all disease, but
Hmm.
especially in cancer therapy, it has shifted from just looking at it as a large occupying, we used to call it space occupying lesion. Even today also we call it space occupying lesion. But the space is less important nowadays. The biology is more important. So now we are looking at the cell biology. We are looking at the molecular biology. Molecular biology's classification, stratification, and also finding out that which pathway should be, I mean,
Yeah.
approached, which will give you the maximum benefit. So yes, molecular approach is nuclear medicine is the key approach of nuclear medicine is the molecular approach, other than the functional. I kept on using the word functional because it is more commonly understood. But yes, molecular approach is very important approach. This is still that we call it molecular imaging modality.
Thank you, Dr. Kaushik, for this very insightful session. And I mean, it was very interesting to talk to you today. Just before you go, any last message that you would like to tell to people? Yeah.
Well, it is difficult to give you a message, but I would like to say that don't refrain from technology, to accept the new technology, but at the same time, don't be dazzled by the technology. Don't over expect. So new technologies are going to come. You should use your logic, clinical approach, clinical ability to find out how much you are going to be benefited from that particular new technology. Don't embrace it without questioning it. At the same time, don't throw it away by some kind of premeditated idea that this is another new thing. It is not going to help us. So technology is going to help you, but at the same time, the judicious use of technology is the most key thing, especially in these emerging fields of diagnosis. So as well as therapy. So that should be a clinician's job, and our all our the physician's job. We should understand that and try to exploit as much as possible the maximum out of it, and stay friendly to the patients. Remember that this is the person who is suffering, so burden the patient list. Try to look up to the patient's overall comfort, as well as the patient's financial situation. So all doctors have a major onus to bear, that you should be empathetic to all your patients.
Thank you so much.
Thank
I
you.
think it was fantastic today talking to you, and thank you everybody for joining this session. And please subscribe my channel, and I think you will get a lot of takeaways from this episode. And I hope we have learned in a short time about a very advanced technology, its pros and cons, how it is changing the paraphernalia of cancer diagnostics, and how judicious use could be a very good way to take the cancer treatment or therapy more forward. And we see less of cancer in the future.
Thank you. Thank you for making people aware of these things. Like, I should appreciate your effort and I
Thank,
congratulate you for doing this thing.
thank you. Thank you so much.
Thank you.